bit more complicated. So, neuroendocrine tumors, what we're dealing with, more on the aggressive end of that. Whether it's a large cell or a small cell, I don't know that it's a point that matters. These cells tend to be very aggressive and they tend to like to go to the liver. So it fits with what's happened.
Right.
The big question will be, again, with the colonoscopy, or is something else going on in there? Hopefully that was just a false finding and all that's going to be okay. Or is something else to happen in your bowel that's been part of this?
Does neuroendocrine go there?
Very unusual. It's unusual.
He said that some of the lymph nodes kind of lit up, so that can happen and it not be cancer.
Correct. Right.
Okay.
Or it could also still be part of this.
Right.
We just got to make sure inside the bowel itself is okay.
Okay.
The reason, and bleep this part out if you ever played to anybody else, because again we're going to fudge a little bit.
Brother, no holds barred, please.
So,
this is me and you right now.
So
man to man.
The reason to call it a small cell is historically those in the large cell neuroendocrine tumors have been tough to treat. The cisplatin VP you got, which we almost killed you with, followed by the carbo VP, have been the treatment of choice for years. Nothing has ever been shown to be better than that up until about 1, 2, 3 months ago with immunotherapy. If you watch TV and you've seen the commercials about Keytruda, Opdivo, immunotherapy, and those are drugs that have changed the way we treat a lot of cancers. Basically, they boost the immune system to attack the cancer. Study came out with one of those drugs in small cell cancers that showed when you added the chemotherapy, people did better. It's not a huge number, but it's where we got to hang our hat right now.
I'll take anything.
About 20% of people can respond to immunotherapy and have incredible responses that can last for a period of time. Because this is now different, to be open and honest with you, with this in the liver, the treatment can put people in remission. It's very, very difficult for a treatment to take this away and keep it away. It's tough to get rid of these now when they've spread. And also, to be open and upfront, the liver can be a tough area. Those cells seem to be a little bit more protected there, but the liver is such a critical organ, you've got to have it to live.
Right.
Because of the multiple locations in the liver and the question of the nodes and everything else, the best treatment is something to go everywhere. You can't go take the liver out. If it was only 1 or 2 spots in the liver, we'd be having a different discussion today. There's targeted treatment, there's even surgery there. Do you do aggressive treatment for that? Well, it's in both sides, and you just can't do that.
There's 3 spots, right?
At least, yeah.
At least, so there could be more. And is it like how big is the liver?
It's about yay big.
And is it kind of spread
And
out?
it's divided into 2 lobes, so
Right.
2 sides, right and left.
Right.
And so the issue is he's got changes in both. So again, if you only had it in one lobe, you say, because you can remove a lot of the liver and it regenerates.
Right.
So
I was gonna say because
yeah, let's go take. It's only in the left lobe. Let's go take the left lobe out. Think about treatment after, and again, you just can't go take it all out.
Because it's on both sides. Okay.
Right. To start with, anyway.
Right.
So again, we need to start treatment like what you went through before, because it's the only thing we got to go everywhere. The carboplatin VP16 is still, again, the best chemotherapy for this.
Should we back down and cisplatin and try it again?
No. There ain't no way I'm giving it to you. You're like you didn't die. I mean, no way.
No bullshit. What was the chances on that one? What would you give me survival pulling through that one once you heard all things considered?
It would have. The data says cisplatin may be 2% better in carbo.
Like when I was in ICU when my bowel ruptured with that right there. Like
how much would it?
When I had liver failure.
No, we thought you were gonna die.
Oh.
We didn't think you were gonna survive. To be honest.
Yeah. True.
Yeah, he absolutely wants the position.
I didn't think you were going to live.
No shit.
No, really. We literally thought I thought we had killed you. I thought our treatment had done what we never wanted to do, that the treatment itself was going to take your life. I thought you were that sick that that's what's going to happen. And to be honest, it's the catch-22 in this whole deal. If you weren't as young as you were, you probably would have died.
So how wild is that coming back from that, something like that? But coming back from that though, like somewhat coming back from that.
In what do you mean though?
Well, as far as the liver.
Oh no,
No. Affected the liver.
Yeah, that and the perforation infection and shock and all that affected the liver.
They could have put more cells towards.
I don't think it.
It didn't necessarily affect the spread.
I don't think that sickness you had affected the spread of.
Oh.
So because typically what's happened is, in patients who have their cancer come back, the cancer was already there when they were first diagnosed. It was just so small we couldn't see it.
Right.
And over time it grows enough where you actually see it. So back then, even when you were sick as you were, there were already some cells there, and they were so small they hadn't grown.
Right.
And that extra damage or anything didn't add to making any of this change. If that makes sense.
Yes, sir.
Okay.
I see where you're coming from.
Yeah. But because you were so sick, it just would be extreme.
I didn't really grasp it. I didn't understand a ruptured bowel. I didn't understand the severity of the situation at hand.
So if you did that now, it would kill him.
If we the problem is we do that now and it creates the same issue. Now it would, because now
things are
we don't have that same reserve in the liver that we did then.
Right.
Because I had an acute stage 3 kidney failure, but did I also have liver damage?
Right. Well, you had liver damage then from what was going on, but that was able to repair itself.
Okay.
Yeah, because the good thing about liver is it does regenerate.
Right.
But
But we can't run the risk of doing that. Even if you didn't perforate and get sick, the concern is the platinum's going to get your kidneys again, and you can't keep treating through that.
Right. The kidneys are already hurt anyway.
Right, and the kidneys already felt the effect of that.
Yeah.
Right. So you got to stick with the carbo.
Okay.
Even though, to be honest, it didn't work.
Right.
Because this is back. Now, but again, those drugs are still the best we have for this type tumor. And typically, if you are 6 months or beyond completing a treatment, those drugs have a reasonable chance of helping again. And you're right at that 6 month. You finished in January.
How soon do we think this started? Would you recommend?
It's been there the whole time. It just finally got big enough
to see it.
Yeah, things are so small that they don't show up on scans until they get a certain size. So they were probably growing the whole time.
The whole time. And even though the last scan you had all looked good, it was there just again was so small, we didn't pick up on it.
But the fact that it's
blood work wouldn't even pick up on it.
The blood work, a lot of times the blood work tells us a lot of nothing.
Okay.
Yeah. And for a lot of people, they'll come in really sick and the blood work looks fine. It just doesn't tell you.
Gotcha.
If that was the only thing we had, then I would tell you the chances of the drug helping you are pretty dang small. And then even if they do help you, the time those drugs would help you is probably shorter. Because usually when you start a second round of drugs again, the chances of them helping you is less than what it was to start with. And if they do help you, the time that it lasts is usually shorter.
Right.
This is where immunotherapy comes in. It's the extra oomph to try to make a difference overall. Because adding it to the carbo VP in the studies in small cell were shown to make a difference. And the way it works is you add to a drug called Tecentriq, which we'll get to, with the carbo VP. You do it first day every 3 weeks. You do 4 rounds of chemo. If you're doing okay.
So is it going to be 3 days again?
Same deal, 3 days. We do 2 rounds, another scan. If that looks like things are getting better, we do 2 more. Think about the PET scan again. If that looks okay, then you drop the chemo off. And you stick with the immunotherapy by itself for 2 years.
Every month?
Every
3 weeks?
Roughly 3 weeks for 2 years. the data says, and to be honest, if we're sitting here 2 years from now and we're talking about stopping it, we're happy.
What's the chances of that?
They're small, but they're they're the only hat we got to hang on. Because I'll get to your foundation study in a minute.
Okay, that's what I heard that.
So if you take small cell,
right.
If you want to know all this, you want these numbers
wide open. Everyone you got in your mind, I want it all out right here.
So if you take small cell, first diagnosed and spread with carbo cisplatin VP, pick your drug. The survival's only about 10 months.
Okay.
When you add immunotherapy, the data says it extends it only to 12 and a half months.
And that's giving them 20% if it works.
And that's giving it, but the data may not be quite mature yet.
Right.
Because this is all new, and the more time we follow this, we'll see where those numbers shake out.
Yeah. But
it extends the people alive at a year from like 30% to over 50%. So it is extending things out.
Okay.
But also, there's people that don't respond to it, to be honest, and there's people who do, who potentially that will extend out even further.
Right.
The reason it's your best option, and the reason I think we got to call this small cell is the other chemotherapy drugs for these aggressive neuroendocrine tumors are not good. There's a drug called topotecan. The response rates to it are very small. The chances of it helping are not fantastic, to be honest. Your foundation study, if you remember at the beginning, we did that special test looking at the genes of the tumor.
Yeah.
And so we're learning more about what the cancer cell does, and we're learning more about how those cells behave, and a lot of the treatments are being developed to target those specific changes. You had several changes in your tumor, but today the science of that is ahead of the treatment science. So the vast majority of the targets you had, there's no drug against those targets right now. You had one target that was indeterminate in you. And that target, there is a group of drugs called PARP inhibitors. They're oral drugs used a lot in ovarian cancer now, breast, and some data in prostate cancer that targets that specific pathway. But I'm afraid of that drug in you up front because your result was kind of indeterminate. So I think you can put that in the back pocket when we think about down the road, but I think, again, it doesn't make sense to start with. It's the chemo with immunotherapy with what you're dealing with that make the most sense.
Gotcha.
Now you're young, so you got a couple other options. One is, do we go somewhere big and look at a clinical trial? Is there some other study out there? The problem with you is going to be there are not a ton of trials for these neuroendocrine bowel tumors out there. Now what they may say is, oh, it's a solid tumor period, can we modify and get you in that? But I don't know that I'd even start with that based on what you're dealing with until you gave the immunotherapy a shot. Now, if we did start immunotherapy and you don't tolerate it, or if we look and it's not working, then I think the clinical trial option is the best way to go.
Right.
Because to be honest, there's not a ton else out there that I think is going to, at least standard treatment, provide you much help.
Gotcha.
The chemo you know about, you're right, same deal, 3 days. The immunotherapy, right now they're all given IV. What these drugs do is basically boost your immune system to attack the cancer. The problem is, when they boost the immune system, they can attack normal parts of the body. So the side effects of these drugs are the itises, pick a body part, arthritis, colitis. That's another reason we got to make sure the bowel's okay. Hepatitis, the liver, pancreatitis, pneumonitis, the brain, pick a body part. The risk of that, though, is very small. The biggest risk is colitis because that can get people very sick very quick. Knock on wood, I've never had a patient have that.
My grandpa had colitis. My brother's got ulcerative colitis.
But I've had a couple people who have pancreatitis, and their reports very, very small percentage. It's very, very small numbers of people can get this diffuse inflammatory reaction that can kill them.
Right.
The key with those drugs is you've got to be very careful, as if something's bothering you, you got to call. Because if it looks like it's the drug doing it, the quicker we know, stop the drug. Steroids help calm the inflammation down. You can get people through it. But if something's going on, you can't just say, oh, well, like I said, this may happen because, these drugs can potentially do some things. Sometimes they can do the strange things. The number one thing we've seen is thyroid. It affects the thyroid gland. I've had a couple people overactive thyroid gland, most people underactive. It's not unusual to see these drugs affect how the thyroid, and usually you just treat through that and move on. The other inflammatory stuff you got to be careful with. But again, that's the drug. If you're doing okay and things are okay, that's the one you stay on for the 2-year period of time.
So that's the
That's the
immunotherapy.
And the chemo's the same, and the data in small cell is platinum VP with immunotherapy.
So the chances of the autoimmune drug flaring him up is what?
We've been pretty fortunate that the risk of those are pretty low.
And he's young.
It's just the problem is if they hit, sometimes they can really
hit.
I've had 2 pancreatises. They were both mild. Stopped. Things calmed down. We got, and you're right. You're gonna. Most of these are older folks. We've got an older gentleman today who's got, I think it's just muscles, and so we're trying to determine if we can even start him back. I've had a couple people, I thought their liver function test went up a little bit. Stopped the drug, that got better. Again, a lot of thyroid. You just, again, treat through it.
So this is for 2 years.
Yeah. And I think I've had one person, to be honest, die from the drug, and I've had one person that went blind that I thought the drug did. Inflammation of the nerves of their eye.
So he needs to take that.
But most people in Tecentriq, knock on wood, for most people we've had on Tecentriq, we haven't had any problem. That people really seem to tolerate that drug pretty well. Opdivo's, again, if you watch TV, Opdivo, we use the lung cancer and couldn't get that one. We've had more trouble with. Then K-Treat was the next one. That's where I've seen the pancreatitis. The Tecentriq, it seems to be, compared to the others, really well tolerated. And you're right, that's the one you stay on for 2 years.
And I'm okay, so then this is way more in depth than what I've ever been through. So like we're talking chemo and that for 2
together. Chemo, if he does okay and it works.
Right.
Chemo for only 12 weeks.
Oh, okay. So chemo for 12 weeks.
Right. So you chemo with immunotherapy to start with. He tolerates it okay and it's working. Usually we only do 4 rounds of chemo.
Okay, so chemo for 12 weeks.
And stop it in immunotherapy by itself.
For 2 years.
Right.
And that's a pill. No, that's an infusion.
Yeah, the immunotherapy right now is still.
And you're saying that if all this works like it's supposed to, he's looking at. I heard you say something about 10 months and 12 and a half months.
Right. If you look at the numbers, that's what you look at.
So if you treat everything right now with the best of what you got, everything works as good as it possibly can work, it'll be 10 months, it'll be 12 if it takes the immunotherapy.
Yeah, right.
Damn.
So you're looking at best case scenario is a year?
A year. No, average. That's average. So again, you've got. So let's say we start this treatment.
So the 10 months and the 12.5 months is average.
All median. So let's say we start this treatment, and in 6 weeks we do a scan and it's worse. Then obviously we're going to be a whole heck of a lot more worried about it.
Now, what do you?
If we do it and it's better, all right. First piece of reasonable good news. We do 2 more. We do the PET, and the PET's negative again. Best news he could get. And then you're hoping and praying the immunotherapy holds it.
Right.
Because those patients, you don't know where they are in the spectrum. You don't know, are we not going to relapse in 2 years? Or are we going to relapse in 10 months? You don't know till you get there.
So you don't even really have a 5-year.
You can't give a 5 year.
They're in the 5 year. But these drugs are so new, there's no 5 year because it doesn't even exist.
There's no 5 year because it doesn't exist, so that doesn't mean there's not a 5 year.
Right, correct.
So what do you call this right here? Like if you break the stage and the letter that goes with the stage and the name, like if you break it all down in scientific terms, write it down for me on some paper. I want you to sign it.
So with the liver.
I want everything, starting from the first one I had.
Yeah.
I want it all wrote down on something and signed.
Research.
Yeah.
No, on something like on a piece of nice letterhead. And
So
his
that you
handwriting, and I want it
so
signed.
that you can show it to him in 5 years.
Yeah, I keep everything on my refrigerator.
Mm.
Like every
He does.
hospital
He's
bed,
got like
my port.
goals of things to beat.
Right.
You're not gonna meet a person with a stronger mindset than me.
And that makes the biggest of differences. So very important.
And prayer.
Also very important.